So we are excited to be here with you this morning, and feel free to ask questions as we go along. As far as disclosures, we've got no financial disclosures. Neither of us are funded researchers in any way, or funded people other than what we do. Opinions are our own. Please understand that we both consider ourselves pretty early adopters based on sort of the evidence and where we see the trends going. There's plenty of seats down front, guys. Come on down if you're interested. So we may be reading the tea leaves a little bit for y'all today, but this is at least what we think. But at the end of the day, it's incumbent on ourselves to read the literature. So go back and take a look at these 4 papers that we're going to talk pretty briefly about and see if you make the same conclusions we do. Last but not least, our better third, which is Carrie Harvey, who is also listed on the program, is not here today. She's an EM intensivist at Michigan. It turns out she not the best mom if she's traveling at the very end of her 3rd trimester to Vegas. So she is not with us today, but here in spirit. And we've done this talk for a couple years on a variety of different subjects. So what are we going to talk about today? First and foremost, sepsis. Who can't start talking about sepsis? We've got the sensor trial. We've got a lot to talk about and unpack from this really relatively new trial out of Thailand. We're going to talk about the PREVENT trial, which was an ICU-based airway trial. Turns out they even manage airways up in the ICU. We'll see if it actually relates to our practice in emergency medicine. POCUS, this is what defines us in the emergency department in a lot of different ways, and we'll sort of unpack the shock DD trial a little bit more. And last but not least, cardiac arrest, which at least Colin and I feel is really honestly the disease process that emergency medicine owns first and foremost. So we're going to talk about these 4 trials as we get started. So I'm going to start off with SENSOR. SENSOR was a single-center randomized trial out of Thailand looking at about 300 patients who was presenting to the emergency department with suspected sepsis and hypotension, right? So can't technically define them as septic shock because none of them were resuscitated yet. What they did was randomize 150 patients to early norepinephrine. The moment they suspected sepsis and they were hypotensive, start them on 0.05 mics per kilo per minute of norepinephrine. The standard treatment arm, 150 patients receiving sort of standard surviving sepsis guideline care, 20 to 30 cc's per kilo, antibiotics, et cetera, et cetera. Primary endpoint in this trial was reversal of shock. Okay, it wasn't mortality, but this is actually a well-regarded variable in critical care. It's not that sort of high-level mortality that we always talk about, but it is a really important question. Do these people have less time in shock than their colleagues? They were also secondarily looking at safety as a profile, so arrhythmias, organ ischemia, and pulmonary edema, right? And then last but not least, they really just were looking at mortality, which we always look at, but that was a secondary outcome, and they weren't powered to look at that necessarily. So here's their mortality curve, right? Let's get right to the most important thing everyone cares about. When I look at this, I see a difference. Stats says otherwise. And so statistically, there was no significant difference between the early norepinephrine arm versus the standard treatment arm. But again, it sort of passes the eyeball test. There's something there. There's at least a signal there. Did it reverse shock sooner? Absolutely. The norepinephrine group reverse shock, had shock under good control as defined by a map of greater than 65 and signs of adequate organ perfusion, which was defined as either lactate clearance or urine output. I know we don't use urine output a lot in the emergency department, but man, I watch urine minute to minute in the ICU, right? And so that was their definition. They definitely showed a significant difference in how fast we sort of change the shock state if you start them on low-dose norepi early on in their course. So what are we taking home from this study? I think first and foremost, it showed that it's yet another sort of nail in the coffin of fluid resuscitation and sepsis, right? Does the tank need to be absolutely positively full for us to really think that it's time for vasopressors to be indicated in these patients? Most importantly was the safety profile of these early norepinephrine group. Less arrhythmia, less pulmonary edema, no difference in organ ischemia, right? So starting norepinephrine early, despite not being fully fluid resuscitated, very safe according to this study. The other thing we have to remember is sepsis is a dysfunction of SVR. Not every septic patient has a problem with preload. In fact, many don't. And so we really need to be thinking about the pathophysiology. Now, am I certain that this is, I think this is safe. I think that's definitely true of this trial. Is this going to show a mortality benefit? I don't know. The biggest trial to date that's coming out, I think it'll probably be 2021 when we get these results, is the Clovers trial, looking at a 500 cc bolus starting norepinephrine right there, and then versus the sort of standard care arm. And we'll see what happens. The other thing I want to point out, because evidence-based medicine is important, is I have a lot of colleagues that really sort of don't pay much attention to this trial. It was published in the Journal of Respiratory and Critical Care. It's a single-center trial out of a developing nation in Thailand. Let me tell you something. This was a really well-done trial, and I think we really need to be careful about discounting where trials are done in today's world, because this was just methodologically really strong and solid. And when you look at the patients in this trial, they look just like my patients. The Thai people tend to be a little bit skinnier than we in the U.S., but let me tell you, they found a pretty sick and pretty sort of US-like population. It turns out diabetes is happening everywhere in the world. Okay?
The other interesting thing about sensor, before we move on, is that a lot of the norepinephrine was started peripherally. Yeah. I know that's a big bugaboo in the emergency department is, we can give some fluids, I don't have to put in a central line. They showed a very robust safety profile with peripherally administered vasopressors, which really takes away an obstacle from starting it earlier in our resuscitation.
Absolutely, absolutely. So to me, the take-home point of this trial is norepinephrine in sepsis with hypotension, it's pretty darn safe, even peripherally. And while it doesn't hurt these patients, it maybe helps them and probably really stems the tide early, getting sort of at the basis of the pathophysiology that's happening to them. So certainly I'm going to be starting norepinephrine a little bit earlier in my patients than waiting to fully fluid resuscitate them. The next trial we're going to talk about is the PREVENT trial. Maybe some of you have heard about this. I certainly have. I got called to a code the other day on the floor, was having a really robust conversation in the middle of it as we're about to tube with the MICU fellow who was like, we can bag through RSI. Didn't you read PREVENT? It was not the time to have that conversation, but nonetheless, you're going to be hearing about this. Because what was this trial? It's a randomized, multi-center trial of bagging through RSI. So what they did was, at the time of patients being intubated in an ICU, there was standard of care, which is true RSI. Push your drugs, wait a minute, go. This trial said the intervention arm was push the drugs, bag them through it, and then intubate them. What they were looking for, primary outcome, was lowest oxygen saturation from the time of induction right on through to 2 minutes post intubation. They also secondarily looked at severe hypoxia as defined as less than 80% sat. Lastly, they were looking at aspiration, right? Safety. How many of these people actually aspirated? Now, their definition of aspiration is a big question mark because it was the person managing the airway either indicated they watched them aspirate while they happened or knew infiltrate on chest x-ray within 48 hours after intubation, okay? And so what did it show? This is a beautiful picture of what they were demonstrating, which is not surprising. All the dots are the actual SATs of the people in the trial. This is the bag valve mask group. What you can see from the eye bar is that on average they had a higher oxygen sat if you bagged them through RSI versus the group that didn't get bagged. Furthermore, secondarily, they had way less people in that severe hypoxia group, as defined as a sat of less than 80%. They also interestingly found that aspiration was actually less in the BVM group versus the no ventilation group. I mean, not statistically significant, 4% versus 3%, but still less in the BVM group, which is a little bit confusing to me. So what's my take home as an emergency intensivist? First and foremost, I don't know about you guys, but the patients I'm tubing in the emergency department are distinctly different than the ones I typically tube in the ICU. All of my patients that I tube in the ED seem to have spaghetti hanging out of their mouth, a pickle. I don't know what it is, but they always eat right before I decide to tube them. In the ICU, the moment I see that O2 sat going this way and my support going this way, I make them NPO, right? I do not sit there and let them eat the cheeseburger while I'm thinking that they're going to develop worsening and worsening respiratory failure. These are two distinctly different populations. And so I think the aspiration risk is still a huge question we we need to be thinking about. The other thing is the airway guru that taught me in residency always taught me that an ounce of prevention is worth a pound of cure. How do we prevent hypoxia? Pre-oxygenation, right? And so that was a big question in this trial. A lot of the, in fact, 40% of the bag valve mask group got bagged prior to induction, whereas only about 10% of those that weren't getting the BVM during induction got bagged. That's a recruitment, right? That's a lot of recruiting that alveoli. And so there's a huge difference in those two groups. And so I think, again, pre-oxygenation is quite honestly the king that we need to take away from this. At the end of the day, one of the things I do like from this trial that they did really well is, man, their bagging was pristine. And we forget this sometimes. I find that when I'm working with my trainees, they get so excited when they get that laryngoscope in their hand. That's all they're focused on. Seeing cords, passing tube, that sort of thing. But at the end of the day, we all know that bagging is the way we save lives. Honestly, doing it two-handed technique with a PEEP valve, with potentially an NP-OP airway in place is the best way to do this. So if there's one thing it reminded me is bag better is always the right answer in patients when we need to. So what was my bottom line? In the emergency department, RSI is still absolutely the way to go. Pre-oxygenation is king. It's stuff we already know. However, if I'm forced to bag, it's probably better than letting somebody get really hypoxic. But the question is, even on their sort of primary and secondary endpoints, does a single SAT of 80 or 76% when it comes right back up ever actually hurt that patient? I'm sure my SATs have been a little bit low after nights in Vegas. I'm sure they are too. So that's pass it over to Colin for next steps.
All right. So we're transitioning now from the airway to ultrasound. Now, I'm not a ultrasound fanboy. I don't have a butterfly. I'm not ultrasounding people on the train or my animals at home, but there's some people out there that are. The question that this study was trying to ask is, in our most delicate patients, the critically ill, those with hypertension, does a protocolized approach to ultrasound actually affect outcomes? All right. This is a multi-center, internationally done RCT with places in North America and South America, done by trained point-of-care ultrasound attendings and residents. So this isn't the person with no ultrasound experience whatsoever. And what they were doing is, someone came in with hypertension, systolic blood pressure less than 100, a shock index over 1. And they either did clinical gestalt, history, physical, and then their normal diagnostic pathway, or clinical gestalt plus a protocolized ultrasound exam. This included your traditional transthoracic echo views, looking for LV function, RV function, effusion. They also looked at your traditional fast views, had two inferior thoracic views, looking for effusion and lung sliding, then also looked at the IVC and the aorta. Did this for every patient that met their inclusion criteria. The inclusion criteria in this study is incredibly important. One, they're hypotensive, yes, and variable consent. But the exclusion criteria certainly affected the outcomes here. No history of trauma. You couldn't be pregnant. You couldn't have had a cardiac arrest. No STEMI. Or if the physician walked in the room and was like, I think I know what's causing the hypertension, they were excluded from having this POCUS protocol applied to them. All right. So as a result, the patients that they actually looked at turned out 80% to be occult sepsis, and applying that POCUS protocol to that population. Their primary outcome was survival to either hospital discharge or 30 days. As you can see by the confidence interval all the way to the right that's highlighted, it was not statistically significant. So I'm not an ultrasound fanboy, so I could just take this paper and rub it into the nose of my ultrasound director being, honestly, in the critically ill, I don't even know why you're bringing it into the room. One, that would be rude. And two, it's actually not true. Right? I still think ultrasound has a place in resuscitation of the critically ill, and you just have to know the caveats. The first is that they designed the study to really favor the null hypothesis and to favor that you're not going to find an actually statistically significant finding here. They took out folks we know would benefit from ultrasound, our trauma patients, our pregnant patients, our cardiac arrest patients, right? And then they designed a protocol very broadly that actually didn't fit the population. In sepsis, obviously, you want to look for lung consolidations, biliary pathology, kidneys, skin things. None of that was actually involved in their protocol, so they were looking for the wrong thing if they were trying to actually influence outcomes. The second thing, and we see this not uncommonly in critical care, is we're evaluating a diagnostic modality, point-of-care ultrasound, as a treatment, right? Chest x-rays don't improve pneumonia. Swan-Ganz catheters don't improve CHF. It's what you do with that information to then tailor treatments that is actually going to be impressive for your patients. Similarly, point-of-care ultrasound is not going to fix hypotension. All right? And lastly, when I speak to the great resuscitationists who also are in the world of point-of-care ultrasound, when they're using point-of-care in the resuscitation bay, it's most helpful when, one, their gestalt then leads them to a discrete ultrasound exam, not a broad protocol. They have right upper quadrant pain, we're looking at biliary. Right? They have cough, we're looking at expanded lung fields, etc. And also, it's most helpful when it switches the phenotype of the disease that you think you're treating. Patient comes in, febrile, hypotensive, has a cough. You're like, oh, this is sepsis. Let's fire up 30 cc's per kilo. You look at their heart and their LV is dilated with no squeeze. That's a huge phenotype switch from septic to cardiogenic shock, and that's where point-of-care ultrasound is going to be powerful. Right? So despite the fact that I could rub my ultrasound director's nose in this study, I don't think it's justified. Point-of-care ultrasound absolutely has a place in the most critically ill. The last study continue to use ultrasound in a focused manner. You're answering discrete questions with ultrasound, not applying it broadly to too broad of a population. All right? The last trial we're going to talk about was actually published in the last month or so in the New England Journal of Medicine. It's called the Coack Trial. And the question it attempted to answer was, at 2 in the morning, after an out-of-hospital cardiac arrest, without clear signs of ST elevation on the EKG, when do these folks need to be cathed? So the first thing is, this is not if they need to be cathed. All these folks will probably require PCI. But when? Should you wake up your interventional cardiologist, fire up the cath lab at 2 in the morning, or can it wait to the day, to the banker's hours of cardiology? So what they did in this study was, if there was a cardiac arrest with initial shockable rhythm that then went to the emergency department, got return of spontaneous circulation, and at no EKG showed ST elevation, do you either, within 2 hours, very quickly get them to the cath lab to have the coronary squirted looking for an unstable lesion, or do you send them to the ICU, targeted temperature management, neuroprognostication, all the good critical care stuff to try to optimize their neuro outcome, and then cath them later when they've had neuro recovery. All right? What they found was that there was no difference in either the rapid, quick to angiography and PCI versus a more delayed strategy. The reason I bring this up is our interventional cardiology colleagues will have absolutely read this paper, and when you call them at 2 in the morning, they're going to be like, well, the Coack trial, so I'll see you at 9. Right? I would say that that may be a little bit of a misinterpretation of the data. All right? And this is why. So this was done in 19 centers in the Netherlands. The Netherlands has a slightly more homogeneous population than we have here in the United States. And dare I say, with their national health system, probably a healthier one. Less than 20%. All these folks got cathed, by the way. It wasn't. And less than 20% actually had an unstable coronary lesion. Right? I work in East Cleveland with an underserved population that does not have great primary care. And I would think that if we did this here in my population, that number would be higher. And obviously, a benefit to early PCI would likely be realized. Secondarily, when on subgroup analysis, if you had a history of coronary artery disease, or if you're older, over 70, and it was their pre-specified subgroup, there was a trend toward benefit for early PCI. Right? Because it's more likely that that out-of-hospital cardiac arrest was of cardiac etiology. And lastly, in real life, we don't make the call for PCI based on EKG alone. There's a story, there's a narrative, there's a patient presentation that actually influences your decision making. So that same patient comes in, out-of-hospital cardiac arrest, initial shockable rhythm, you get them back, no STEMI. But their partner comes up and is like, well, for the last 4 days, whenever he's gone up the stairs, he's been diaphoretic. He's had chest tightness going to his right shoulder and his neck. and oh, his dad died of a massive heart attack about the same age. I think that person you should absolutely advocate should go to the cath lab, even though they don't have a STEMI, because your pretest probability of a coronary lesion is so high. So the bottom line, if the story is terrible against ACS, it was an out-of-hospital cardiac arrest, there was no great narrative that this is actually a coronary cause, you can perhaps wait to the morning. However, if you have a high-risk patient that has a great narrative for acute coronary syndrome, they probably will likely benefit, especially in an American population, from going to the cath lab. Good news is this will not be the last piece of data on this question. We have the AXIS trial and DISCO that are currently underway that ask a similar question, so we'll have more data on this. All right. It was 8 in the morning. We just did 4 studies in 20 minutes. We thank you very much for showing up. I hope you learned some things and can now go back to your emergency department with a bit more nuance on these 4 papers, and hopefully it'll affect your most critically ill folks. Thank you.